Welcome to everyone who is joining. I see there are people actively entering, so we're just going to wait a couple minutes while folks can join, and then we will get started. Okay, welcome everybody. Thank you all for joining us today to participate in this conversation about how states, counties, and cities can help young adults access Medicaid and SNAP. The recent changes to federal SNAP and Medicaid policy have significant implications for young adults' access to these critical supports and for the role that states and localities have in ensuring access. While we've been planning this webinar, I keep receiving invitations to related webinars with other organizations. Everybody is talking about this, and it's a really important topic. We heard from leaders at the National League of Cities, the National Association of Counties, National Governors Association, and National Conference of State Legislators, among others, that a webinar with today's focus would be useful. Even if everyone's talking about it, it would be useful for us to have this one as well. Our conversation today is focused on the millions of young adults, ages 18 to 24, who rely on SNAP and Medicaid for a successful transition to adulthood. Our discussion today will focus on practical, promising approaches and ideas that state, county, and city officials can use to improve young adults' program access. Over the next hour, we will have brief presentations from several speakers, followed by an open discussion. To set up the conversation, Urban Institute experts Jennifer Haley and Elaine Waxman will provide overviews of key policy changes in Medicaid and SNAP and their implications for young adults. Then, to kick off the discussion of ideas, we will hear from 4 speakers who will share insights, strategies, and examples for positive action. Following their comments, we encourage all of you to jump in to share your own strategies or to raise questions for others. Before we get started, we have a few housekeeping notes. We will be recording during the initial presentations so that we can post this online and share it with people who weren't able to join. However, we will stop the recording when we get to the open discussion so everyone can feel more comfortable sharing and asking questions, even if you wouldn't want to make those public. During the presentations, everyone else will be muted, but the Q&A box is enabled so that you can submit questions or comments at any time, either with your name or anonymously. And the Q&A box on some screens, you might see the chat more visibly than the Q&A box. You might have to click on the 3 dots, and then you should be able to see the Q&A box for submitting your questions. When we get to that Q&A segment of the event, you're also welcome to share your camera, raise your hand, come off mute, so we can have an open discussion. Or you can continue submitting things through the Q&A box, and I will raise those anonymously. The live transcript option is enabled, so you are welcome to use that, but you can also hide the captions or adjust the settings as you wish. And after the event, we also encourage you to check out Urban's Young People in the Safety Net project page to learn more about our work on young people's access to the supports that help them thrive. It is now my honor to introduce my colleagues Jennifer Haley and Elaine Waxman, who will discuss the implications for H.R. 1 for young adults' access to Medicaid and SNAP. Jennifer Haley is a Medicaid expert and a principal research associate in Urban's Health Policy Division. Elaine Waxman is an expert on nutrition assistance. She is a senior fellow in Urban's Tax and Income Supports Division. Please welcome Jennifer Haley.
Thanks, Heather. I'm so excited to be with all of you today. I'm Next slide, please. Just going to start with a little bit of background on Medicaid for young adults. So eligibility for Medicaid is much more restrictive for adults, including young adults, than for children in every state and varies by state. As you can see from this figure, the median Medicaid and CHIP eligibility threshold for kids is much higher than for adults, and the median threshold for both parents and other adults in states that have adopted the Affordable Care Act Medicaid expansion is 138% of poverty. But for young adults in the 10 states that have not adopted the expansion, the median threshold for parents is just 33% of poverty, and there are no pathways to Medicaid eligibility for adults without children who aren't pregnant or disabled. So, related to this low eligibility for Medicaid, as well as the lower likelihood that young adults have employer sponsored insurance compared with other adults, young adults are already more likely than any other age group to be uninsured. And uninsurance among young adults is higher in non expansion states and among those with lower incomes and racial and ethnic minorities. So, already a population that's not necessarily getting all of the access to health insurance we might wish. Next slide, please. The reconciliation bill has several provisions that will reduce Medicaid enrollment by a projected 8 million total over the next 10 years. And these represent the largest cuts to Medicaid in the program's history, reducing federal Medicaid spending by almost $1 trillion. And many of those provisions target that Medicaid expansion. So the legislation includes both direct changes in eligibility as well as several ways that increase administrative burden for applicants and enrollees, which will result in fewer people being enrolled, even if they technically remain eligible. And today I'm going to talk about 3 specific provisions among many that are in this law and how they will affect young adults. Next slide, please. So as of January 2027, states are required to redetermine eligibility for ACA expansion enrollees every 6 months, twice as frequently as prior to the law. Young adults who will be at high risk of coverage loss due to this provision include those who are transitioning from parental homes or foster care or experiencing changes in living arrangements, such as moving, in which case it'll just be harder for states to reach them for that more frequent redetermination, and to get the paperwork to them, they'll have to complete and send back in many cases. And then young adults who lack support about how to obtain that documentation, how to navigate those processes, will especially be at risk of losing coverage. Next slide, please. The second provision is HR 1 mandates that states apply work requirements for Medicaid expansion coverage. So also in January 2027, quite soon, enrollees ages 19 to 64 will have to work, volunteer, or participate in a job training program for at least 80 hours a month, or be enrolled in school at least half time in order to qualify for Medicaid unless they're exempt. And those characteristics include things like medical frailty, being a parent of a younger child, other categories. Importantly, these work requirements apply not only to enrollees, so they have to be found compliant or exempt at least every 6 months, but also for applicants to the program in the month or months prior to applying for the program. Urban Institute and other evidence from the small number of states that have previously implemented work requirements has highlighted the importance of automatic data matching for determining compliance and exemptions. And if people have to take action to prove their compliance or exemption, they'll especially be at risk of coverage loss. So young adults like gig workers or students might really be at risk of losing coverage if the states don't have data on whether or not they're compliant. The next slide shows the third provision that I'll mention today, the termination of Medicaid eligibility for many lawfully present immigrants, including asylees, refugees, survivors of violence. Sorry, this slide's something seems to be messed up, but I'll just let you know that this immigrant rules will matter for eligibility for those who are directly affected by the loss of eligibility for those immigrant subgroups, but could also have implications for people in those families who might remain eligible, but because of confusion or concerns about immigration consequences might not apply. So just to wrap up, the Medicaid changes will likely result in extensive Medicaid coverage loss among young adults, reducing the health services access and use. At the same time, there are a number of marketplace restrictions which are happening at the same time. And overall, we expect to see increases in uninsurance among young adults during this time. So effects are also likely to vary by state. And that's it for me. I will pass it over to Elaine now. Thanks.
Thanks, Jennifer. So you got a little bit of a preview here on the first slide on SNAP, but I just want to start by acknowledging that this is a particularly challenging week to talk about SNAP because of the shutdown and the likelihood that SNAP benefits will not be made available on time starting November 1, as they normally would be. You may have heard that approximately 24 states' attorney generals filed a suit today to try to compel the administration to fund the benefits. But, obviously we don't know what will happen there. And at any rate, it's likely to be delayed. So for those people who are currently on SNAP, this is very disruptive. And I think we can expect a pretty tough November just in general with respect to food insecurity. But for now, we're going to turn to the broader picture on SNAP. Next slide. And I think it's always helpful to remind ourselves all of the ways that SNAP can matter for young adults. SNAP reduces poverty. This is a known and demonstrated fact. And it is an evidence-based strategy for reducing food insecurity. And food insecurity is associated with many poor health outcomes, both near-term and longer-term in life. And so we particularly value SNAP as the sort of universal tool that's available for most low-income people should they meet the eligibility criteria. SNAP is also a work support. People often turn to SNAP when they may be out of work or experiencing unstable work, but it also helps people in low wage and unstable jobs maintain that work. And I think that gets lost sometimes in the narrative. And then finally, SNAP is not easily available for post-secondary education students. But is there for some, for example, if they are enrolled at least half-time and if they are also working and at least half-time. So next slide, let's talk a little bit about what the recent changes may mean. So most young adults are subject to work requirements. Sometimes we use the term work requirements without understanding that in SNAP scenarios for young adults without dependents, or if they, for some reason, would only have an older dependent, that carries a time limit. So it's not just that they need to meet a work requirement, but if they're not able to successfully meet it, and that requirement is working 80 hours a month or in equivalent activities, they actually are limited to receiving 3 months of benefits in a 36-month period. That's a pretty draconian policy penalty. And so that's one of the reasons why we want to really think hard, particularly in this sort of turbulent period, how to try to preserve people's participation if at all possible. I should say that there are some exemptions from these work requirements that folks can apply for example, for physical or mental health issues. But the rules are changing. Communication can be very confusing. It is not unusual for states who are sending out new notices to not be able to connect that notice to the right address for someone, particularly young people who may have more frequent moves. So I would just say that many people in the field don't fully understand the changes that are coming. So we definitely should not expect the average beneficiary, let alone someone who is fairly new to the system, to be able to navigate it easily. The other change that I want to mention is that undocumented immigrants have never been eligible for SNAP. That is a narrative that you will hear, and it is not accurate. And certain other legally present individuals may be eligible, but they have a 5-year bar. So even after they have legal status, they have to wait 5 years to participate. So SNAP is relatively unavailable, and appreciate everybody's participation in trying to make that more clear to the public at large. Unfortunately, there have been some recent changes for certain immigrant groups, particularly refugees and asylees, who are now ineligible for SNAP. And so if you have young people who fall into those categories, they may be surprised to find that they can no longer receive those benefits. Next slide. So I mentioned before exemptions, and those can be important, but it will be much more difficult to get exemptions. In the past, counties or groups of counties with high unemployment rates, higher than average for the nation, were able to qualify for a waiver of work requirements based on those labor market conditions. And so we now have a very high bar for states being able to secure those waivers. And so the unemployment rate has to be 10% or higher. That's Great Recession level unemployment. And so not typical in a lot of places, but if your local unemployment rate is 9%, it's not a robust economy either. So if people have lived in areas, in some states, for example, have had statewide waivers, California, Illinois, some regions have consistently had waivers even post-COVID. People will be surprised that there are new requirements now for them. In addition, for the last couple of years, we've had automatic exemptions for certain groups that we knew would struggle more with maintaining work, and that included individuals 24 or younger, transitioning out of foster care, homeless individuals, veterans, and then parents of children 14 and up. In the past, all parents of dependent children were exempt from these specific time limits, but that's not true now of older teenagers in households. So the last thing I'll say is, in the past, caseworkers could help negotiate individual exemptions for people for physical or mental health reasons. It appears now that the new guidance is going to require medical documentation, which can be a real barrier. In some places, it's hard to even get a medical appointment. And you may or may not have Medicaid or some other health insurance coverage. So that's very challenging. Next slide. So you're about to hear from some great practitioners that can talk a little bit about things that can be done. But I'll just mention that just based on the rules changes that we're seeing, I think outreach broadly to help clarify some confusing communications, to make sure that people are even aware that changes are coming, is really helpful. We will need more supports to help people maintain the eligibility, given that 3-month time limit within 3 years if people can't meet that work requirement. And that means helping people with documentation, helping them apply for exemptions, and then possibly helping them find ways to meet the work requirements through other activities if work is not available. So with that, I will pause and pass it to my colleague, Heather, and look forward to more conversation.
All right. Thank you, Jennifer and Elaine, for those overviews. It is now my pleasure to introduce the next 4 speakers who will share resources and strategies for furthering access to SNAP and Medicaid for young adults. Alex Briscoe is the co-founder and principal at Public Works Alliance. He's going to share some optimism related to opportunities in the current context for youth mental health and Medicaid. Darla Bardine is the executive director of the National Network for Youth. She will share information on the Vital Document Legal Hotline for youth. Robert Gordon is currently a distinguished visiting fellow at the McCourt School of Public Policy at Georgetown University. And as of last week, he is also leading state initiatives for the new Recoding America Fund. He will share practical ideas from his recent work, as well as from his time implementing work requirements as the director of the Michigan Department of Health and Human Services. And then Kyra Pospisil is the commissioner for the Department of Social Services in Greene County, New York. She will share a tool that New York State is using to achieve positive outcomes for timeliness of SNAP, Medicaid, and other public assistance. Alex, we will start with you.
Thank you, Heather. Hope everybody can hear me. And I'm going to move really quickly. And I'm going to try to find a silver lining in a really difficult time. So I just want to acknowledge as well the most difficult circumstances around both these extremely significant cuts to California safety net systems. But the good news is, if you're looking for it, we did not get block granted. The EPSDT entitlement still exists. And states across the country are doing really extraordinary things with their youth mental health systems. In fact, there's an emerging consensus around systems change in young people. And I'm going to tell you sort of the essential elements of those and then quickly highlight two of them. So first, states across the nation are removing diagnosis as a prerequisite for care. I spent my entire career working in high acuity settings with young people and leading a large health system. And almost every child historically has qualified for care based on a diagnosis. And now we are using new either social determinants of health or adverse child experiences to qualify young people. And this is a really important evolution and change in access criteria. Second, we are reimagining the workforce. More than 20 states have written state plan amendments for community health workers, including numerous other types of extenders or provider types, community health workers, wellness coaches, behavioral health technicians, doulas, or other birth workers. We are seeing a fundamental reimagining of the behavioral health workforce in youth mental health with formal acknowledgement that not everyone needs a 50-minute psychotherapy session. Next slide. Next. Led by extraordinary work at 0 to 3 and a number of other actors, we are now codifying what we call dyadic care, meaning that caregiver mental health and pediatric primary care is being built into our reimbursement practice. There are multiple ways to do this, from per member per month payments to visit enhancements to defined benefits like California's dyadic benefit. But they're all playing on this idea that babies don't go to the doctors by themselves, and that low-income communities interact with the healthcare system the most frequently in the first 3 years of their child's life, 12 times. So let's treat caregivers while we can. Next, California just did this, but states across the country are looking at how to formally tie the reality that managed care plans are the center of the Medicaid universe. In fact, 15 million children have moved from fee-for-service to managed care plans over the last decade in America. And some states are trying to think how to formally tie that managed care plan enrollment to schools. So California just literally passed a state plan amendment and new regulatory framework across both Medicaid and commercial plans that make schools and institutions of higher education, public institutions of higher education, automatically a network. And finally, fifth and finally, children under EPSDT are not restricted by budget neutrality. Because of the unique structure of the EPSDT, the federal entitlement, the federal government must match all eligible non-federal expenditures, meaning almost every state has child serving systems that are spending eligible non-federal dollars, what we call certified public expenditure. So get your hustle on. Look for those parking taxes, opioid dollars, tobacco funds, dollars that you're spending in your child welfare, juvenile justice, or public education system on healing work that are going unleveraged and unmatched. So these are the 5 essential strategies that are driving change, and I'll highlight 2 of them. When we think about the new provider classes, which is, I think, the most exciting opportunity, there's 5 things to think about. First, what is the scope of practice? Meaning, what codes can be built and under whose supervision do these new providers work in? Next, credentialing. Who gets to say they are who they are? What's your process for providing a credential for this new provider type? Third, paneling. How do they sign up to get paid? And please, individual actors don't exist in healthcare systems. So let's not try to force our community health workers or doulas into solo practitioner status. We must build organizations through which they can. Next. Payer, meaning most states still have some legacy public mental health carve-out system. Are you billing managed care plans? Are you billing a 1915B waiver? What's the structure of your safety net mental health system? Finally, rates. If the rates are too low, it doesn't work. We need to get to 85 to 90% of Medicare, or we're not even in the game. Anything that's 50 to 60% of Medicare doesn't work. Let me end with this. Well, I'll end with this one maybe just because I'm running against time. Next slide. I'm just going to show you why these provider classes are so important. there'll never be enough therapists. But let's say you're a young person in a high school and you want to be a therapist and you're working in a peer-to-peer program in a high school. Before, we would say to this young person, oh, get your master's degree and we'll see you in 4 to 8 years. And a lot of young people say, hey, I'm going to be dead by 30. What are you talking about? Now, and you can just keep clicking with me, you can graduate and become a peer specialist. You can become a community health worker. You could become a doula. You could become a wellness coach with an associate's degree or a wellness coach with a bachelor's degree. We're now allowing interns and associates to bill in FQHCs. This is a really big one. Master's degree clinicians who haven't yet earned their license are just now being allowed to bill in FQHCs. And then finally, we have a therapist. And my point on this is that we're trying to recreate the health career pipeline for young people to get care in non-clinical settings from people who look like them and who they trust. My last 2 slides are on the statewide all-payer fee schedule, but the way to think of these 2 slides is we passed a law that makes schools automatically a network for all managed care plans for 4 types of services and for different types of providers: community health workers, wellness coaches, and master's degree therapists. And finally, it is open to every K through 12 education, every public K through 12, every public charter, and every public institution of higher ed. And the way to think of this is young people 8 to 24 use the healthcare system the least. So we must reimagine who does the work, the workforce, where it happens, the schools, and schools have to be the center of any response at scale to these striking increases in utilization and acuity. So as I pass it off to my colleagues, there is some hope in HR 1 that at least children pass through with their federal entitlement intact. They will be deeply impacted. Undocumented children won't present for care. Young people, as we heard earlier, will lose their insurance. But the uncapped unique federal entitlement that Medicaid confers upon children still exists. And there are essential practices that all states can use to make life better for young people. Thank you.
Thank you, Alex, and thank you to Urban Institute for inviting me here to be a presenter on this really critical webinar. I am here to talk about a really important issue. Many young people experiencing homelessness. We focus on youth homelessness, but also a lot of young people who are systems involved, so involved in the legal system or child welfare system, really struggle to access their vital documents like birth certificate, Social Security card, or a valid government ID. And without those things, it is very difficult for young people to access the public benefits that they desperately need. Next slide, please. Okay, this is the opening slide. So we have partnered, the National Network for Youth has partnered with Baker McKenzie Law Firm, who has gone above and beyond in their pro bono work. And we have launched a vital document hotline. So it's a free legal hotline for young people. You can call, you can text anytime, but I put the hours on here. Operators are available on Wednesdays. So if you want to talk live to an individual, you can call 11 a.m. to 7 p.m. Central, 9 to 5 p.m. Pacific. But messages are returned. So you can call a young person, or someone helping a young person can call anytime. Also, you can text anytime. And there are lawyers who will return phone calls and text on Mondays and Fridays as well. Next slide, please. So this is, sorry, the formatting is a little bit off. I think it got lost in translation. But I wanted to answer some frequently asked questions that we get. So who is answering the phone or the chat? So it is pro bono legal professionals and lawyers, but it is not legal advice, okay? All the lawyers in the room know what I'm saying. You're not getting legal advice, but you are getting information from lawyers. Do you need to be experiencing homelessness to call? No, this is not, coordinated entry through the U.S. Department of Housing and Urban Development. Any young person can call. And in fact, we've had people of all ages call, and we don't turn anybody away, though this is a hotline that was created to help young people. What happens when you call or text? So if it is during operating hours, you will text or talk to somebody directly. You might have to wait on hold. Some days there's just a higher call or text volume than others. Outside of Wednesdays, like I said, your text or voicemail will be returned. Who's organizing the hotline? It's us here at the National Network for Youth, as well as Baker McKenzie. Next slide. We are asking for help to spread the word. We want as many young people as possible to know about this hotline, as well as people who are working with young people. So we have a lot of youth homelessness providers, McKinney-Vento homeless liaisons in schools. We have youth workforce and employment programs calling. All sorts of different folks are calling. But then the primary people who are calling are young people themselves. And what we have learned in the limited time is that about 20% of the young people who call actually need legal services. They actually need a lawyer in order to access their vital documents, either because they're a minor and there's parental issues, or they don't even know who their parents are. They're from the child welfare system. And they didn't get any support from that system. And so we are building out a legal referral network so that we can refer those kind of 20% of callers to pro bono lawyers who can help them through the processes that they need to. Please use this QR code, and I'll put the link in the chat. We have templates you can share on social media and newsletters, websites. We have flyers you can print out and hang up if you're working directly with young people. And my final slide, next slide, please. We are hosting a webinar with Baker McKenzie next month on November 19th. So if you want to learn more about the hotline, feel free to join us. Thank you. And with that, I'm going to pass it to Robert.
Great. Hi, everyone. I'm Robert Gordon. It's great to be with you. First, I'm just going to talk a little bit about my experience in Michigan with implementation. I don't have the deep experience that others on this call do with working with young people and trying to extend access to them. I will say in Michigan, we had to implement a work requirements law because it had been added to the state's Medicaid expansion before I became the state's HHS director. It was a policy that at the time the Governor Whitmer, who I was working for, and I, her appointee, thought was misguided, and yet we did the best we could to implement it. One of the tragedies of the moment, which I think will be the tragedy that we see a year from now, is that in spite of the best efforts, enormous numbers of people who were doing the things that the statute asked them to do were on track to lose their health insurance. And that arose as I said, in spite of best efforts. And we really went above and beyond to try to do as much data matching as we could, to do the kind of direct outreach and and plain language and human-centered design in forums, in online flows that would enable as many people as possible to comply with the statute. And yet still we were on track for, I think, 100,000 people to lose their health insurance in Michigan until the statute was enjoined. So I think, unfortunately, there is a little bit of that, or a lot of that, that we are going to face regardless of best efforts. Having said that, and particularly for those of you who are advocates, I will say I think that the decisions that states make are going to make an enormous difference. And a year or two from now, we're going to see large differences in the extent of coverage loss by state. There will be very large differences. And some of that will be kind of exogenous factors, like were they Medicaid expansion states? What was the population mix of families? People who are older, children. But a lot of them will have to do with state capacity. A lot of them will have to do with the state's data systems, the kinds of investments they make in user-centered design, the kinds of investments they make in their staff. If there's one thing that I think will make an overwhelming difference, much as I love to talk about human-centered design and the importance of enabling people to connect and meeting them where they are, I think the single thing that will have the biggest impact is the extent to which states create data flows so that people who are eligible to have their Medicaid renewed, or to be found eligible, have to do as little as possible or don't have to do anything. That's what we saw with ex parte and unwinding, where the states that there was a huge correlation between the extent of people losing their Medicaid and the extent of people not being ex parte renewed. And we will see the same thing. We will see that the states that are able to automate these data flows, whether it is Labor Department data, whether it is data from the health providers that's in an MMIS system that identifies who, for example, is medically frail, whether it's demographic data, who are the kids, where are they living, what are their addresses. The states that can get those data flows going are going to be the states that have the most success in minimizing coverage loss. So what else does it take? If we go to the next slide now, this is just a list of factors that I think and we am with a new effort to build state capacity to enable states to better address challenges like I've been talking about. What are the things that you want to see states doing? I think it's the kinds of things on this list. Some of it is just good management. You want someone in charge. You want a team that's focused on implementation that's different than a policy team. You want real-time performance management so that regularly agency leaders are meeting with their teams and saying, where are we? You want clarity around goals. You're going to need, particularly as states are required to build new modules to comply with this law, much faster forms of procurement, much faster legal reviews, and you're going to need GCs who are acting within the law, but to the broadest extent of their authority. You're going to need budget, and it's a very difficult situation because obviously part of what this law does is reduce matching funds for SNAP and impose additional, obviously there's other cuts in the system, additional demands at a time of reduced resources is a huge challenge. And then you're going to want to create learning across states. So these are all dimensions that will matter enormously. I just want to speak to one thing, and this will be my last comment, that is specific to the situation of young people and everyone who's at the edge of compliance. And now you can just go to the next slide. I testified before the law was enacted about my experience in Michigan, and I talked about what to me was this very striking feature of the statute. This is from Don Moynihan's blog. He put my testimony up on the blog. My apologies in advance. I left out a comma, which if you read it, you will find. But the basic point is that the way the statute is drafted, how do you establish that you are eligible to keep your Medicaid? You establish it by working, being in school, um, being in one of the fully exempt statuses, doing community service, or being in something called a work program. And you might think that someone who just lost their job and is all they're doing is looking for another job, that person would be exempt because they're looking for work. But that is actually not the way the statute is written. It's not enough to be looking for a job. You have to be in something called a work program. The reason this is relevant, I think, particularly for young people, one, there are challenges right now for lots of people finding work, particularly if they're young, out of school. But second is this question of what a work program is. And I think there is an opportunity for states to be creative within the letter of the law and think about setting up new work programs that provide meaningful training or opportunities consistent with the statute, but which individuals can also easily get into and demonstrate that they're in. And I think that has the potential to create another vehicle, particularly for young people who may be out of school and aren't able to find work, to be doing something that betters themselves, enables them to continue to comply, and does not necessarily have all the bells and whistles that we are used to seeing in what we think of as a full-blown job training program, and maybe isn't the job training program that all of us might want for people in a more normal circumstance. So I just share that as one idea that's been on my mind in what is obviously a circumstance that I at least wish we were not in. So with that, I will stop and turn it over to Kira.
And thank you very much. Thank you, Robert, and thank you to the Urban Institute. So I'm going to present what EVA's impact is on Greene County DSS, and you will quickly figure out who EVA really is. So next slide, please. So Greene County, just so you have a reference, the population is a little over 47,000. We're located in the southeast central New York, just west of the Hudson River, in the beautiful, beautiful Catskill Mountains. Our department has 101 employees. We cover all the programs from Office of Temporary Disability Assistance. So that's all the TANF programs, that's child support, that's SNAP, that's HEAP. OCFS is Office of Children and Family Services. So that's our CPS teams, our foster care, our adoption, our adult services, our prevention cases, and DOH's Department of Health, where we have obviously the largest caseload, which is Medicaid, and our home care programs that our nurses oversee. Next slide. So here's the problem. As we all came out of COVID with staffing problems, we had this amazing time frame that we needed to keep for all the clients to keep everything flowing. And as you can see, I was only able to determine our cases on public assistance on time 53% of the time, and on the SNAP side, only 55% of the time. The reason the Medicaid cases aren't here is because we were able to extend them, and we extended them to the end because we just weren't able to get that work done. To make it even worse, the cases that were late, that were 60 days or longer on public assistance was 19%, and on the SNAP side was 24%. So there was a major impact on the people in the community that we serve. Next slide, please. So we needed to look at something. What were we going to do? The county didn't have a lot of money. We weren't able to get a lot of staff, so we needed to do something different. So we did do something majorly different. We did a contract with TIPCO Automated Systems that started in June of 24. That organization is out of Ohio. So eligibility verification assistant is EVA. And there was 3 components that we started with. I'm going to talk about 2 of the components. The first one is what we call R&R. So what it did is to streamline the interview. It basically read the rights and responsibilities, and it reduced the time the employees were on the phone. It actually reduced it between 8 and 12 minutes per interview. And at this point, we've done over 1,600 of those calls. On the EVA phone, we actually went live with the latest version, which is amazing. It did automated responses to phone inquiries. Next slide. And this is what we're looking at. The first half shows you in June of 24. And once I put those pieces in place, fast forward to August of 25, my cases that I determined within the required timeframes, public assistance, 96%, SNAP, 98%. And amazingly, I had no late cases. Not one of my cases was over the 60 days. That was really attributed to the EVA system that we contracted for, which is absolutely amazing. And when you take a look from 53% to 96% and 55% to 98% on the SNAP side, clients were getting the services that they actually deserved. Next slide. So the impact, we reduced weekly overtime. We enabled the agency to expedite all the eligibility determinations. It provides helpful, productive solutions, and it's available 24/7, 365. Clients can leave messages at midnight if they want to. It's clear and concise. We have the return phone calls for that. The staff are happier. The clients are being served. And there's one piece in there, because I did these slides last week that I didn't put on. But believe it or not, for the size of our county, work participation rates are very, very, very important. In August of 24, we were only at 3.8%. And as of last Friday, hot off the press, we are 35.5%. We are ranked the #1 county in New York State at this point for putting clients back to work. So we are very proud of that. And it was really this product that really helped us do that. The next slide, please. The next slide, I broke down the calls for you. At this point, they've taken over 16,000 calls. It's over 268 hours of staff time. And the majority of that is general questions. We can feed the information into EVA, and she digests it overnight, like on the website. Like right now, I'm updating what's happening on the SNAP side, and she will get that all correct, and she'll give out the correct information. So customer services was quite a few of the calls. And then you could see in the programs, SNAP was the #1 program that questions were asked. Then it was Medicaid and HEAP, and then CPS. So this just really shows you how it's kind of broken down. We can take a look at the analytics and do many different things. But we've been very, very pleased. And we've turned around something that was not working. And I'm still behind by several examiners. But this has really made a major impact for us. And I'm so proud of the team here and so grateful to TIPCO for what they've done.